What is up, my beautiful brainy babes, and welcome back to another episode of Sex as a Biological Variable, where we dive into both the science and the soul of being female. I'm Dr. Rosie Ray, and even after earning my PhD in biomedical science, there's still so much that I wasn't taught about my own body and brain. So that's what we're doing here, learning from the scientific literature and the lived experience of women to talk about what's really going on. So let's dive in. Hey guys! Welcome back to the show. Where are we? What's going on? Hi, hen. Well, it's March. It's the end of the quarter. Congrats to all of my fellow corporate baddies out there. We did it. I'm in Detroit. My apartment is coming together very nicely. I'm so excited. It's turned out really nice, cute, cozy. Everything that I want it to be. And yeah, where am I at in my cycle? I just got off my bleed. This was a good shed. There has been a lot that has happened this month. And so just kind of being able to release that has been really good for me. But yeah, I'm feeling good. I'm feeling great. Very excited about this episode. Today, we're going to be talking about hormone replacement therapy. Now, there are a lot of different types of hormone therapies, birth control, gender affirming treatment, but today I'm specifically going to be talking about it in the context of menopause. First, we're going to be talking a little bit about the history of hormone replacement therapy, just to give a little context. And then instead of going through all of the different types of hormone therapies, that there are different ways that you can take them and the different things that they do, I'm just going to be talking about what my plan is for hormone replacement therapy in like 20 some years. And then the last 20 minutes of this episode is really cool. It was recorded in an OBGYN appointment. I went with my aunt to advocate for her to get on hormone replacement therapy. And I got permission from my aunt and from the doctor to record. And so that was really cool. But I think just being able to bring those conversations out into the open, be able to have that vocabulary circulated for women that are wanting to go on hormone replacement therapy, just things to think about because there's a lot that you might not know. So what is hormone replacement therapy? It can be a treatment for menopause. Now, if you haven't listened to the menopause episode, I highly recommend going back and listening to that. I talk about all of the physiological changes that are happening in the body, but basically, menopause is the halting of reproductive processes in a woman's bodies, particularly in the ovaries. The ovaries, they stop producing all of the ovarian hormones. The main two that I'm going to be talking about today are the primary ones. The first, estrogen, big mama estrogen, and then progesterone is the second. And so those are the two primary ovarian hormones. But in menopause, during the transition can take a couple years, but during that transition, a woman's ovaries will stop producing these hormones, and then after that, she is no longer able to reproduce. Now, menopause is a natural and a very healthy part of aging, and so it's weird for me to think about it as something that is being treated for. It's strange that women have these ovarian hormones for our entire life, and then halfway through, about 50 years old, then women just don't have these hormones. And according to all of the literature, it absolutely wreaks havoc on a woman's body. And so being able to take something to supplement the loss of those hormones, I think can be really, really powerful. So a little bit about the history of hormone replacement therapy. HRT first came onto the scene in the 1930s. This was a product that was derived from human placenta. Yum, all natural. Then in the 1940s, it was shifted to a conjugated form of estrogen, which was derived from pregnant horse urine. It's a weird one, but shout out Pfizer, you did that. So then in the 60s and the 70s, estrogen was really popular. We've talked about it before. Estrogen is an extremely prolific growth factor, but when estrogen is unopposed or not taken with anything, those growth effects can not be great. And like our hair loves estrogen, our skin loves estrogen, but you know who else loves estrogen? Cancer. Cancer loves estrogen. And so during this time in the 60s and 70s, when unopposed estrogen was really popular, there was this extreme risk for endometrial cancer, and that was just cancer of the endometrium. So then later in the 1970s, they wised up and said, okay, we need to have something to oppose estrogen. We need something to kind of keep the brakes on estrogen, and that is progesterone. That's that secondary ovarian hormone. And progesterone is really important to keep the brakes on the growth effects that estrogen has. And I think it's really interesting because not only does this happen like molecularly in the body as far as like with cancer and other tumorous growths, but it also happens in the brain at a synaptic level where we see that estrogen has this growth effect, which can be good, but sometimes leads to like increased anxiety and heightened arousal. But when progesterone is on board, that tamps that down. And so progesterone is kind of cool. So then moving into the 90s, 1998, the Women's Health Initiative started the biggest study on hormone replacement therapy. Something like 27,000 women that were involved in this study. Biggest study ever done, biggest study that has ever been done on hormone replacement therapy. And in this, there were a couple different groups. There were women that had uteri and they were given estrogen, which was in the form of the horse urine estrogen, and a progestin, so a synthetic progesterone. There was another group of women that were hysterectomized, and so they didn't have their uterus. They were just given unopposed estrogen, which like, I don't know about that one. But then as all good studies, they had a control group that was placebo, and so they weren't taking any hormones. The benefits that this study was seeing included a decrease in osteoporotic fractures, there was a decrease in colon cancer, and there was no significant increase in breast cancer. There were a lot of good things that came with hormone replacement therapy, but there were some bad things that came with hormone replacement therapy. But what they found in the group that was taking both estrogen and progestin in the combination is that there was an increase in coronary heart disease as well as breast cancer, which like, we hate that. We absolutely hate that. And so because of that, they stopped that early. They published those results, I think, in 2002, but the other groups, they continued that, which like the unopposed estrogen, like yikes. But that study finished in 2004. And what they showed for the group that was hysterectomized and taking unopposed estrogen was that there was a slight increase of risk in ischemic stroke, which is not good. We don't like that. But these were small risks. And then this was on top of all of the benefits. And you got to also think this was a study of 27,000 women done in the late 90s. And so there probably wasn't a lot of tailoring to the specific woman. And now the media got a hold of this and there was widespread panic in the media, in people. I went to doctors as well. And now my beef with this is that the types of hormones that they were using were synthetic. So they were using the estrogen that was derived from horse urine, synthetic, ethinyl estrogen, and then they were using a progestin, which is also synthetic. And like those are known to have more side effects. Those are not as readily absorbed by our body. And so it's like, I don't know if they would have seen that if they were using bioidenticals. But so after this study came out, there was a lot of panic around hormone replacement therapy. So because of the results that were in that Women's Health Initiative study that then got totally twisted by the media, that definitely played into this narrative about hormone replacement therapy that still exists today, even though the medications have come a long way, the science has come a long way, the understanding has come a long way, the treatment has come a long way. But that narrative, it's still lingering around. My thinking with it is that hormones it's a double-edged sword, and it's so sharp just because they are prolific growth factors, but not being able to tailor it to the specific individual and not having something that is similar to what our bodies are already producing, like that's a recipe for disaster. And so if we can tailor it, and then if we can have something that is going to be easily taken in by our bodies, like the risk for it is so low and the benefit is so high. So another thing that can be really tricky about hormone replacement therapy, it's not only what you're taking, but it's when you're taking it. And so this is referred to as the timing hypothesis. And this has to do with when a woman starts taking hormone replacement therapies in relationship to when she went through the menopausal transition. Now, the window of opportunity to have the biggest benefit is obviously going to be closer to when the woman is going through menopause, but that window of opportunity is about 10 years long. So a woman could have gone through menopause 10 years ago, but she can still benefit from hormones 10 years later. But obviously, like if you nip it in the bud closest to when you're going through the transition, that is when you're going to have the biggest benefit from these hormones. Now, the concern is that if someone starts taking hormones outside of this 10-year window or the window of opportunity, is that there's an increased risk for cardiovascular disease, fatty buildups of plaque around the heart. If that gets dislodged, that's a blood clot, and like we don't want that. If you're over 55 and you're thinking about going on hormone replacement therapy, go to your primary doctor, go to your cardiologist, get your heart checked. They're going to be looking for a C score, a calcium score, and they're also going to be looking at the cholesterol deposits around your heart. And having an idea of like where you're at with baseline is going to indicate if you would be at a higher risk for some type of heart disease taking hormone replacement therapy. So there are different types of hormones out there, but today I'm just going to talk about what my plan is. So a little bit about my hormone backstory. I haven't been on birth control consistently since 2016, so it's been about 10 years. And I don't plan on taking any type of hormones until after I'm done having kids. And my reasoning for that is because I eat right, I sleep right, I exercise, I try to keep my stress levels low. I have been working really hard to keep my hormones happy in just the way that I live my life. And that's not only for my own health, which that's a hack. Taking care of yourself is, your life will just be so much better. And it's I look good, I feel good, but my health is going to be a hormonal blueprint for my children. And so I'm just trying to set them up for success. So what? I'm 28. The best time for me to have kids was probably 6 years ago when I was 22, but I was busy. I was busy going to school and having fun and being a kid, being a girl. And the biological clock is definitely a thing, but I'm trying to get my mental right. I'm trying to get my money right. I'm trying to find the most elite baby daddy for my children. And all of those things, I'm not trying to rush any of them. So I can wait. I'm gonna wait until all of those things are in line for me. Now, in society, just out in the world, I know that it's considered a geriatric pregnancy if someone has a kid over 35. I think that's wild. I think that that's absolutely wild. And I know that birth defects and mental impairments, the risk for that goes up after 35. But I'm an optimist. I'm a healthy girl, and God willing, I will be able to have all of the babies that I want to have when I want to. But ideally, I would love to be done having kids by 42, which seems a little old, but we're optimistic. So then after I'm done having kids, let's say 42, I got my eyes on menopause. The average age of the menopausal transition in the US is 51 years old, but I'm of the mindset that there are so many small molecular changes that are happening incrementally to lead up to a woman actually losing her period. And so what's called perimenopause starts mid 40s, but there's also something in my brain that tells me that once a woman has children, her biology is all right, we have done our biological duty. We are shutting down the factory. I don't know. I mean, there is some research showing that the later you have kids, the later you go into menopause. So maybe that's why that's in my brain. But yeah, once I'm done having kids, I'm going on hormones. So there is different flavors of hormones. There are synthetic hormones, which is the horse urine derived estrogen. Now, these hormones are common in birth controls. This is going to be ethinyl estrogen and progestin. And these, like I said earlier, they have more side effects. They're not as readily absorbed by our body, and we have a little bit more of a reaction to them. And now, on the other hand, there are bioidentical hormones, and this is estrogen and progesterone. These are plant derived, and they are the exact same chemical structure as the hormones that are in our bodies. And so they're going to be readily absorbed by our body, and we're going to have a lot less side effects with them. So something that I want to stress so much is that in hormone replacement therapy, you need both estrogen and progesterone. Kind of like we were talking about earlier, estrogen is this crazy powerful growth factor, and progesterone keeps the brakes on it. If you are taking estrogen unopposed, no doctor should be prescribing you that. But if you are taking unopposed estrogen, that's going to open you up to so many things: endometrial cancer, breast cancer, colon cancer. No good. We don't want that. And then I do also want to stress the difference between progesterone and progestin. So progesterone is that bioidentical, same thing as what we have in our body, whereas progestin with an I, that's going to be the synthetic version. And that's going to come with more side effects. That also opens a woman up to different types of cancer. Eesh, none of that. And now before I really started digging into it, I just thought, oh, once I'm done having kids, I'm going to go on birth control because that's the hormones. But after looking into it, there are no current birth controls that are completely bioidentical hormones, estrogen and progesterone. There's 2 brands that are making what they're calling a natural birth control, and they have estrogen, a bioidentical estrogen, but they still have a synthetic progestin. Thinking back to that Women's Health Initiative study that was done in the late 90s, that was that same combination that was leading to an increase in breast cancer and coronary heart disease, which don't want that. Don't want that. So no birth control for me ever, except for natural cycles. But after I have kids, then I will be going on to these hormones. So the delivery method of these medications historically has been a pill, like an oral medication that one takes. But now my preference would be a transdermal patch. This is like a little Band-Aid looking thing. You know, those circular Band-Aids, those really tiny little ones. You stick that on your body somewhere, your butt, your thigh, your stomach, somewhere, and you have that on for 3 days and then you switch it out. And what's really neat about this is that it avoids the first pass metabolism by the liver. And then with this, really with any medication, you want to start on the lowest effective dose. And this is something that you need to work with your doctor to figure out what that is for you, but starting at the lowest dose and then figuring out if you need more based on your life. And now in addition to this estrogen patch, because we don't want to have unopposed estrogen, you will also be, or I will also be, taking a oral progesterone pill. And this is something that you take every single night. Progesterone is good for relaxation, so it's good at nighttime to help you sleep. But again, very important that this is a bioidentical progesterone, not progestin. And that's because progestin increases risk for cardiovascular health as well as different types of cancer, which like we don't want. So my long-term plan for this hormone replacement therapy, so say that I start taking it when I'm 42 years old, I enter into the menopause transition, perimenopause at like 45, I'm well prepared. I take hormone replacement through the menopausal transition, and that's going to help with my symptoms. It's going to help with hot flashes, mood swings, brain fog, frail bones, losing my hair, changes in body composition. Say that I stop having a period when I'm 55, but then my ovaries are going to continue to produce testosterone. They might be done producing estrogen and progesterone, but they're going to keep producing testosterone until I'm 65. Now, I've talked to some people and some doctors that say like, oh, you don't need to take hormone replacement therapy after you've gone through the menopausal transition. But my question is, why not? Like, I'm envisioning myself 70, 80 years old on bioidenticals, being a hot, sexy thing, like with a clear mind and strong bones and strong muscles. Because, like we've been saying, estrogen is this really powerful growth factor, and it's so good for all of those things. And like dementia, Alzheimer's disease, estrogen is going to help. Estrogen is going to protect against that. Bone density, osteoporosis, estrogen is going to protect against that. A lost libido with getting old, estrogen's gonna help with that. And so like my thinking is, if I'm losing these magic little molecules that I've had for a majority of my life, and there are these bioidenticals that I could just be taking, why wouldn't I take that? But this is also like in 50 years. And so I hope that I learn more. I hope that things change in the medical field. But like, as of right now, this is where my mind is at. So yeah, I hope that that was informative. I do want to put a disclaimer out. I am a doctor. I am not your doctor. That is just what my plan is for my hormones. But like, you do you, girl. So now let's get into the clinic. Again, this was recorded with permission of my aunt and with her OBGYN, but both of them told me that they wanted to stay anonymous, which like is good, because after the recording, we're going to debrief because I have some opinions. Yeah, I have some opinions, but yeah, let's go. So last time we talked, I'm just looking back to make sure, you were having like pain with intercourse.
Yes.
Did you use the vaginal estrogen?
So there's this tube here.
Yes.
A little clarification.
Yes. For sure.
I called and they told me that I was to use up to number 5 on there.
No, 0.5, which is
Half
a gram. Yep, exactly.
So
I'm sorry about that.
It's okay because it was falling.
Okay.
And I went through like a 40-day supply in a very short period of time. My husband and I did a little research.
Yeah.
And so it's too early to say on how that's going.
Okay, no worries. So if it's easier for you, I'm fine with you using the one gram, just because sometimes it's hard to do like the half. So, but is it easy for you to use this device?
I've been doing it manually.
That's fine. Yeah. So basically just like, that amount, like basically is like, the tip of your finger, and you can place it vaginally. Yep. So how long would you say you've been using it for?
Probably 3 weeks.
Okay. Well, you'll have to keep me posted. Have you noticed any changes in like your bladder symptoms, like any improvement, anything?
I haven't really noticed.
Okay. Okay.
You weren't really having much, like, any leakage or anything like that, right?
No.
Okay, no burning with peeing.
No.
Okay, good. Perfect. Okay, good. So essentially, I just want you to keep using the vaginal estrogen. Basically, for maintenance, you can use it once a week. So,
right, that's where I am right now.
Yep, so you can use that 1 gram once a week. And then if you're noticing dryness still, then bump it up to twice a week.
Okay.
Okay. And then if you need any like further refills or anything, let me know.
Okay.
Are you having any symptoms of like hot flashes, night sweats, anything like that?
So wake me up in the middle of the night, and I haven't been getting good sleep at all.
Okay.
Even though I'm on trazodone.
Yeah.
I still have some difficulty falling asleep, and then I wake up with episodes and I can't get back to sleep.
Okay.
And so the insomnia has been very difficult.
Pretty bad.
And which is why I brought my niece, because I really wanted to have more conversation about the possibility of hormone replacement therapy.
Yeah, no, totally. So the hard thing is for you, you went through menopause early. Like I have 45. Yeah. Is that correct? So in our world, hormone replacement therapy should be started within 5 years of menopause.
For the most benefit, that is true.
Yeah. And so, and that's just a general term. Like, so basically what I mean by that is like with estrogen and with progesterone therapy, for the most benefit, but also to reduce the risk of heart disease.
So I worked in a OBGYN clinic with a menopause and hormone replacement specialist.
Yeah.
And he was a big advocate for the estradiol patch.
Right. That's what I use too.
And
yeah.
the risk for that is really, really low.
It is. It's low, but it still makes me a little uncomfortable just because, I don't want to do more harm than good. Progesterone, though, I think is a good idea because progesterone will help you with your sleep. And if your trouble is mostly at nighttime with like waking up and the insomnia,
but it's also with the hair loss. With
osteo. My hair. I had to get it cut because it's
I know you were saying,
out, and I can see my scalp and it's thin, and my skin has changed. And...
Have you in the last year had any like blood work done? Like, has anyone looked at your thyroid levels and
I did,
hormone levels?
And everything was normal.
Okay, when did you check that?
That was in March of last year.
Okay, but when did you feel like the hair loss was at its worst? Now. Why don't we check those levels? Just because March, was basically a year ago. And sometimes those can fluctuate big time. So I want to make sure we're treating you appropriately and like looking at all the numbers. Okay. If that's okay. But basically, so there are some other medications that are not like exactly estradiol. The estradiol, 15 years post-menopause, the data that does show that it can increase your risk of heart disease.
Well, I guess because you said that you started going through the transition at 45, but didn't completely exit the transition because the transition can take on like 10 years on like a high end of it.
Mine was mishmash.
Did your bleeding stop though?
You said that it was about when you were 50.
Yeah, probably about when I was about 50.
You were still having pretty severe symptoms, like really severe hot flashes until you were 55.
Yeah, it tapered off when I was about 55. But it was a hard thing to...
Yeah, it's like a muddied picture.
To try and figure out what was what.
Yeah, for sure. And listen, I'm not trying to say like I am a big proponent of hormone replacement therapy. Like I love it. It's one of my favorite things, one of my favorite, populations of patients. But my job is to do no harm. So I don't want to do anything that's going to cause any problems for you. So I think let's get some blood work today. I want to kind of just do like a hormone panel and just make sure and look at all of your numbers. And it's up to you. I'm telling you the risk. I don't want you to go through any like heart disease and that kind of thing.
Could you elaborate on the specifics of the heart disease that you're concerned about?
So basically it can increase risks of, have you had like a lipid panel or like looked at your triglycerides and cholesterol levels recently or no? Okay.
Yeah, that was in March.
How was that?
Actually, I have a good,
the good cholesterol is good?
Yeah.
Okay, cool.
Didn't you say that you got blood work like more recently, like a month or so ago?
No, it was March. I had my physical was just recently, but all my blood work
Was from March. Okay.
yeah, and everything was good.
Came back good. Okay, cool.
There was no concerns.
Yeah, I guess my thought is that because she has gone through menopause, the estrogen is going to have the greatest benefit now than it would if we get 2 years down the road.
Oh, of course. Yeah.
So, and now, is there a way that we can monitor what you're concerned about with any heart issues that might come up? Is there any way that we can monitor that while she's taking the hormone replacement with the patch?
So, not perfectly, I guess. You know, has your primary talked to you about doing like there's something called a calcium score of your heart where we can look at your vessels around your heart and just make sure that those are all normal?
No.
Okay. But you're due for a primary appointment probably soon, right? If it was last March.
I could be.
Yeah. Okay. So that's one thing that I would recommend. Like if we're going to start estrogen, I do want you to see either your primary or a cardiologist just to do like heart screenings, because I don't want to put you in a position where we're like, why did we do this?
Right.
And like I said, I don't want to cause more problems than, what's already happening. So let's get your thyroid levels checked. I want to make sure that's normal, because that does cause the same, like very similar symptoms of like, And
so if her thyroid is out of whack, then
yes.
What would the treatment for that
depends on if it's too high or too low. But if it's generally thyroid levels at this age are, the TSH would be high, meaning she's lacking in the hormone. So I would get a prescribed levothyroxine.
Okay.
Yeah. To normalize it.
Like my thinking with that is anything that could be going on with the thyroid, I think that could be connected with the loss of ovarian hormones, which could potentially be solved with the estrogen replacement.
They're actually different. So thyroid and, symptoms go hand in hand, but thyroid can cause a lot of like metabolic issues. So thyroid stuff can't really be corrected with estrogen. It's its own separate thing. But they're
not connected at all.
They are connected, but treating with estrogen isn't going to correct a TSH level.
Yeah, I guess I'm just thinking because there's so many things that have changed in the body, and the loss of ovarian hormones definitely plays into the dysregulation of the adrenergic system. And so I think that replacing the estrogen and then having progesterone on board to kind of combat the growth effects of the estrogen would be a really good approach. I'm
not disagreeing with you. It's the hard part is just the time frame that we've been. I mean, if you're telling, because I don't know if this was from your first visit, 45 to now is a really big gap of being completely out of estrogen to starting you on like a regular dose of estrogen. If it was closer to 50, 55, I don't think it's unreasonable to start it. So I just want to make sure that that's accurate. So then I guess what I want to make sure we do is maybe make an appointment with your primary. Let's get all like brand new like cholesterol levels and ask specifically about the C score. And that just checks the calcium around the heart to make sure you don't have like high cholesterol deposits around the heart.
I do think that is a good idea.
And as long as that's normal, I'm fine with starting you on hormone replacement therapy. Yes, patch plus yes.
What type of patch do you normally prescribe?
It's the estradiol patch twice weekly.
Okay, is that the generic FDA approved, or do you have a brand specific that you prefer?
There's really not a good. I usually just do the generic one. Yeah.
Cool. And then for the progesterone, do you typically prescribe progesterone or progesterone?
Progesterone.
Okay.
Yeah.
Cool.
Yeah.
So
Yeah.
that's the bioidentical.
Yes.
Okay.
Yeah.
Excellent.
Yeah.
Cool.
So, and what you will do is you'll take the progesterone nightly, and it's 200 milligrams, and you'll take it every day.
And then what dose will she be starting out for the patch?
So the goal is to use the lowest possible effective dose. Yeah. So I usually will do 0.05 milligrams. And then that's twice weekly. So you'll pick like 2 days out of the week where you replace it. It's a clear patch. You can shower with it on. I usually tell people to put on their belly or on your thigh, and then alternate which side you go on, just because it's an adhesive, so it can kind of sometimes irritate the skin. Yep. Hopefully not, but if it does, just let me know.
Yeah.
What do you think? And then I want to see you back within a month of starting, just to make sure that you're doing okay on it.
Okay.
And that it's actually helping.
Okay.
But I want you to make an appointment with your primary just to get those things done too within the same time frame, if that's okay.
Okay, so just to make sure that I got the timeline correct, so we're getting the script for the patches and the progesterone, and then we're gonna make an appointment to see the primary to get the heart checked out.
Yeah.
And
we'll do also blood work today. Yeah.
Okay.
Yeah, we do it here. Yep.
Okay, cool.
Yeah.
So then by the time that you come back for the checkup, can have the update with how you're feeling on the patch, and then we'll also have the results
Hopefully, yeah. So I can do blood work on hormone levels, but I want you to see your primary for the heart-specific testing.
to look at the calcium.
Yeah.
Okay.
For like heart disease, like God forbid, a heart attack, things like that.
Yeah. And I think with
Because the patch takes completely away the risk of blood clots because it doesn't pass through the liver. Are you? Okay.
Yes, I am.
So, I mean, we can bypass your primary and I can just give you a referral for a cardiologist that I like. And then I want you, if you can, the best thing for your bones is weight bearing exercise.
Yep.
Are you doing anything? Perfect. Okay, good. Keep it up. That's
Like,
okay.
I
It doesn't
do.
need to be super heavy. Yeah, it's just more so like the repeated motions. Okay, good.
So that was cool. That was fun. I did like this OBGYN. I thought that she did a really good job asking questions, being curious. She was really validating, and obviously like not wanting to do any harm, super important for any doctor. And so I commend her on that. I think that that was really great. I do need to expose myself a little bit. I got a little defensive. There was just a few things that I didn't like. I didn't feel like it was dismissive, but I feel like there was just some information there that wasn't completely being talked about. My biggest concern was that the doctor was saying that the window of opportunity after menopause was 5 years, and that she gave it as such like a cut and dry 5 years. And that's so tricky when you think about the menopausal transition. And like thinking about my aunt's transition, it was long, it was messy, there was a lot that was going on. And so being able to say like, oh, you're 5 years past it, and it's like, we don't really know exactly like when it started, when it ended. We have this range. And that was my biggest thing, because it's 5 years for the max benefit. But like we could try it outside of that. Another thing that really kind of put me off was the way that she said it, in our world. And it's like, girl, whose world are you living in right now? Like we're living in like this woman's world, and we need to talk about that. So if you're trying to like say that you're living in a different world, I need you to come to this world. That was a little off-putting. And then also the dismissal of the effect of the loss of ovarian hormones when she was talking about her thyroid being dysfunctional, which like totally valid, definitely could be something with the thyroid. But thinking about the larger scale of the endocrine system, the thyroid is a section of it, the same way that the adrenal glands are, the same way that the pituitary gland is a section. And like it's a really interconnected, it's almost like an orchestra, you know? I'm definitely biased to think that the reproductive hormones have a huge impact, but I mean, like they do, they create new life. And yeah, if her thyroid is being dysfunctional, maybe it's connected to the massive loss of all of her ovarian hormones that have happened. And her saying, no, they're different. And it's like, girl, I know they're different, but like, you don't think they're connected? Because they are. And so that was a little funny to me, but it was a successful visit. We were able to get the script for the hormone replacement therapy. She is now on the patch. She's taking her progesterone. We got those bioidenticals. And then she is following up with her primary and her cardiologist to go get her cholesterol checked again, even though it was already checked and it was looking good. My girl was looking so good on her cholesterol. But then she's also going to get that C-score, that calcium check, to check the calcium deposits around her heart. I had a lot of fun putting this episode together. I hope that that was informative. I know for me, it feels kind of crazy thinking about my plan for hormone replacement therapy as a 28-year-old woman, but like I be thinking about this shit. And so I hope that this can inform anyone about the different types of things, about when you might want to start thinking about it. I think also because I don't want menopause to sneak up on any of the girls. And like, I'm 28, I'm pushing 30. It might be a little bit early to start thinking about these things, but I've been talking with so many women that are in their 50s, 60s, 70s, and they're like, oh, what about hormones? But the window of opportunity is a real thing for the biggest amount of benefit. And for me, that starts, I mean, like the earlier you can start taking care of it, the more benefit it's going to have. And so just things to think about as us girls continue to grow up. But yeah, I love you guys so much. Thanks for being here. I'll see you next time. Okay, bye. All right, my beautiful brainy babes, that is all I have for you today. I have all of the important information that we talked about linked down in the show notes. I also have a link to some hormone-free birth control. Natural Cycles is down there. Thank you all so much for listening. Stay smart, stay safe, and stay sexy. I love you, and I will see you so soon. Bye. Mwah.